done. It is good NPM1 positive. We know that it is favorable prognostic mutation, and it is that's because it is chemosensitive. It produces sensitive, and the next count is very high, and relapse is about or just after 2 years. It is late relapse. So I don't know about the FLT3 ITT positive. It is de novo or it is present in the previous and first diagnosis, because it might be new mutation at the course of the disease process or on the relapse.
It was not assessed before.
Previously. So at this point, FLT3 ITT positive, we say that it is unfavorable or sometimes it is favorable depending on the allelic ratio. I mean that FLT3 ITT and wild type allelic ratio, if it is less than 0.5, then it is favorable prognostic, and it is more than, so ratio is important. So it is more than 0.5, it is unfavorable. So in that case, even sometimes where it is not possible to find out the ratio, then consider it as an intermediate or high risk. At the presence of NPM positive plus FLT3 positive. In that case, we should consider remission induction chemotherapy like the previous one, daunorubicin plus cytarabine, standard dose to 3/7, plus from the day 9, day 8, we can add midostaurin. Midostaurin can be added because it is a specific drug for
targeted drug. You want to start a targeted drug.
So,
yes, sir.
So after that, first remission, we without delay, we go for transplant, because we should decide that there is a fourth sibling. There is a chance of HLA matching. So HLA matching should be done previously, because we don't wait the 1 month, 2 months for matching or something other. So it is better to do immediately. This planning should be done at the very before starting of the chemotherapy. And one thing is that there is blast is very high, number of the count is high, and the number of the blast is high. So it indicates that it is bad prognostic, because FLT3 ITT positive, when it is increased proliferation, at the same time increased relapse, early relapse, and also blast count is high. Thank you very much.
So thank you, sir. So due to time constraint, we are moving to the next case. That is the last case. He is a 2-year boy who has a history of blood transfusion 2 times at 9 months. Sir, Professor Salahuddin Shah, sir, he will answer on this, talk on this, that 2-year boy has history of blood transfusion 2 times. And on examination, he has hepatosplenomegaly, no facial change. With the permission of his parents, I shared this case. And he was found to have anemia on his workup, that is 6.2, the lowest hemoglobin level before transfusion. But his electrophoresis report is hemoglobin F is 98.3%. So the question is actually how we will evaluate the patients who are beta thalassemia major is a diagnostic challenge before the 2 years or 1 year of age. Sir, would you please comment on this?
Thank you very much. We have time constraint. All of you know what are the diagnostic criteria of thalassemia. First of all, clinically, we evaluate a patient through clinical history. Is there any family history of blood transfusion? We know severe thalassemia or transfusion-dependent thalassemia, they need blood transfusion at the age of 3 months, 6 months, and at the age of 1 year from the very beginning. So, clinically, we may think about from family history and treatment history, may be a case of thalassemia major or transfusion dependent. Then we do first time CBC and peripheral blood film. What about CBC and peripheral blood film? Hemoglobin will be low and peripheral blood film special findings. At the same time, that means MCV and MCS will be low. When MCAs will be low, then we may think there is a chance to be thalassemia. Our common test, we do capillary hemoglobin electrophoresis. We are not commonly practicing SPLC. SPLC especially may detect and help to detect or estimate hemoglobin A2. But from our electrophoretic report, for thalassemia major, hemoglobin A will be 0 to 20%, hemoglobin F 80 to 100%, hemoglobin A2 0 to 13%. What about for this patient? Patient's report was hemoglobin A 8.8%, hemoglobin F 98%, and hemoglobin A2 1.2%. For every electrophoresis, before going for electrophoresis, we take history, whether there is blood transfusion history or not. But before 2 years, sometimes we may think at the age of 2 or below 2, hemoglobin F will commonly remain raised. So what will be our final diagnosis for the patient? If we do DNA test, then it will be confirmed. Or another one, very simple. We must have to do hemoglobin electrophoresis for the parents, father and mother. If both of them are trained, then it will be thalassemia major clinically. We don't have all the time DNA facilities. আমার মনে হয় যে এরপরে আর বোধহয় সময় পাওয়া যাবে না। আমি খুবই 30 সেকেন্ড করে আমার প্রেজেন্টারদের সম্পর্কে বলতে চাই। 4 presenters are here. Really, I'd like to give big clap for them, please. As because 3 of them newly passed MD, 1 is senior than that of the newly passed, and all of them are trained. All of them are received their MD degree from Bangabandhu Sheikh Mujib Medical University, and we are delighted and really feel proud that our Vice Chancellor is here. And all of you know, since last 1.5 years, all the residents, they presented in different occasions, and our Vice Chancellor has given them crest for their lovely and knowledgeous presentation. So when I have seen them in the dais, then I'm thinking, oh no, I'm in the morning session. In the morning session, they were trained before. How they will proceed for short presentation? They have been asked to present their topic within 5 to 8 minutes. And in our morning session, we have started. We told them, please complete your presentation within 3 to 5 minutes. They have presented nicely. I feel proud. And the topic, role of NGS, Dr. Smart, role of NGS, how brilliant she is. Next generation sequencing is not only knowledge, it is technical part from the technologists and scientists, another part to interpret and to realize the software and integration of the software findings, that NGS will be effective. We can. And second, Papri Nasrin, she has presented new chemo, intervention of chemotherapy and targeted therapy. And I think we have presented many times on these topics, and nicely presented and brilliant presentation already. আমি ডিটেলসে যাচ্ছি না তাদের প্রেজেন্টেশন সম্পর্কে। থার্ড প্রেজেন্টার ওয়াজ রোল অফ